All right, we're going to go over this interpretation of periapical lesions. We're going to talk about different types of periapical lesions on radiographs, describe periapical lesions, identify local factors contributing to periapical lesions. Periapical lesions most oftentimes are caused by caries. A lot of times it can also happen with trauma or periodontal disease. Basically, what's happening is you have an inflammation from the pulp and it extends all the way down into the bone around the tooth. And so that's where that bone starts to degrade and you get that radiolucent area around the apex of the tooth. The infection actually resorbs the bone down there. So here we have just sort of, you can see from A to B to C and D, we have A is just a widening of the periapical periodontal ligament. Oops, let me go over here. Sorry, I'm on the wrong screen. A is just a widening of the PDL or the periodontal ligament. B is starting to see a periapical radiolucency. C is the periapical radiolucency not encapsulated by bone. And then D, finally, you have this periapical radiolucency, but it's encapsulated with some dense bone. The body's trying to wall off this infection and protect itself, and that's called condensing osteitis. It's a reaction of bone to resist the bacterial infection. So you can kind of see a little bit of those stages here and here. This is condensing osteitis. So sometimes that hangs around even after the root canal or the infection has resorbed, but it's just the body trying to wall off the infection. Periapical lesions are well-defined radiolucent lesions at the apex. You can see a couple examples here and here. And you can start to see a bit up here. The tooth has a crown post without endo treatment up here. So it's just showing some different ones. But it's talking about this one here. I don't know why it says that specifically, but I think it's just pointing it out. Periapical lesions, relatively well-defined radiolucent lesion at the apex. And that's the tooth with the large filling. You can also see something's happening down here as well. So we have a couple other types of radiolucencies that can happen in that periapical region. One is called a periapical granuloma. It is the most common periapical radiolucency in dental practice. It's a localized mass of chronically inflamed granulation tissue, that's immature blood vessels and nerves, at the apex of a non-vital tooth. Non-vital means the pulp has died, the nerve has died. Bodies attempt to neutralize the toxic irritating factor. Often it's asymptomatic and the tooth is non-vital when it's tested. They can do a pulp vitality test. And when they do that, it can come back and say whether the tooth is vital or not. And the requirement is a root canal therapy or an extraction if somebody doesn't want a root canal. And then obviously you'd want to replace it with something like a bridge or an implant. The next one is acute apical abscess. This is painful, localized collection of pus at the root abscess or root apex. That's creating pressure, pushing against the bone, and that's painful. The patient's going to feel it. It's going to be symptomatic. Tooth is non-vital and will probably require the same treatment as up here. Chronic apical abscess, long-standing, low-grade inflammatory. Oops, sorry. Pause this for a second. Okay, I'm just going to start back at chronic apical abscess, long-standing low-grade inflammatory reaction to toxic irritants. Often it can be asymptomatic, often associated with a fistula, so that basically it's almost like a pimple that appears on the the tissue close to the apex. And it's basically like a pressure relief valve where the pus will kind of drain. So that's the fistula. Tooth is non-vital often and requires the same therapy. So requires root canal, requires root canal, requires root canal. All of these, generally, any kind of an abscess generally ends up with needing a root canal, or like I said earlier, if the person doesn't want that than an extraction. So what could be in a radiolucent lesion? It could be air, it could be hollow essentially, could have fluid like blood, cystic fluid, exudate is pus, excessive white blood cells. It could have some soft tissue built up in there. So really there's no way to know. There's oftentimes granulation tissue as well. That's the soft tissue. Um, but if it's a cyst, it's usually much larger and looks different than if it's a periapical abscess. Um, for periapical lesions, there's usually acute exacerbation of a chronic periapical abscess, may lead to swelling. You can see the swelling in this patient's face here, and pain. Not always, it doesn't always end up like this, but it can if there's acute exacerbation. And you can just see there's a lot of bone deterioration around that apex there. So a periapical cyst is usually much larger, and the main difference between a periapical cyst and just a regular periapical abscess is this epithelial lining inside of the cyst. So it's oftentimes fluid filled and it has an epithelial lining. Painless unless infected, tooth is usually non-vital, usually bound by a thin line of sclerotic bone. So you can see this thin line of sclerotic bone around the cyst, and usually larger than a granuloma, originates from pre-existing periapical granulomas. So this is different than like your traditional caries causes a periapical abscess. This is more like some kind of almost like a reaction to some cells, cells kind of acting abnormally, essentially. A radicular cyst is an inflammatory cyst, and it's one of the most common and significant types of cystic lesion affecting the jaw. It's a chronic inflammatory response to the epithelial rest of malases, which occur in the periodontium of an infected tooth, and it's usually symptomless and detected incidentally by a radiograph. So the person usually isn't complaining about it, they just find it. Here's a biopsy of a cyst, and there's just some soft tissue inside. So to summarize the different things that we talked about, these are all basically under the branch or the umbrella of periapical lesion. And then you can have a periapical granuloma, a periapical cyst, a chronic periapical abscess, or acute periapical abscess. So radiographic interpretation of these lesions, we might see condensing osteitis around the apex. Again, that's that body's attempt to wall off the inflammation. Radiopaque border around the root tip, that's what it's going to look like. And you can see this like a cross section, the bone just becomes denser. Here's some more pictures of that condensing osteitis that may or may not happen around a periapical lesion. And you can see some more. And for this one, this tooth is the before, this is the after. But you can see after a while that condensing osteitis was still there. So this picture is before they took out this infected tooth, and then 8 years later they took another radiograph, and you can still see that there's that condensing osteitis. So it doesn't always leave or resorb. There's also something called hypercementosis. You can see it's kind of like an abnormal growth of the cementum, and this can look like some kind of a periapical, some kind of a lesion going on. It's an excessive disposition of cementum, appears as a radiopaque band along all or part of the roots. Periapical radiolucencies, these are obviously not radiolucencies, they're radiopacities, but periapical segmental dysplasia. So it looks kind of cloud-like or sort of like radiopaque, radiolucent, benign, slow-growing connective tissue is inside of this area, and it proliferates, destroys the lamina dura, replaces the bone with fibrous tissue, varying amounts of radiopaque material. So we have some more radio lucencies here. You can see the widening of the PDL. Trauma, we have some fractures, traumatic injury to the tooth. Example, tooth with a crown fracture. Example of a tooth with a root fracture here. Another example of a periapical lesion around this tooth that had a root canal. Another one here. And this is the same picture we saw earlier. Here's another one here. These all look like widening of the PDLs there as well. Same here. There's a root fracture. Here's another one here on this molar. This is just the outline of a socket, but you can see the radiolucency around that. Doesn't look very good there either. So a lot of times it's important to take a good dental history and ask questions because sometimes there can be radiolucencies that may be pathology but may not be, and something might have been there for a long time. Sometimes the patient will know and sometimes they won't. So you just want to make sure you find out if what you're looking at can be documented in past radiographs or if it's new, and just document what you see for the future oral health providers, dental hygienists, dentists who see that patient. All right, that's it for that one.